Delighted to have you here today. I wanted to build on what Elizabeth said, and I called this Getting to the Triple Aim Faster, because I think that we are approaching a lot of this stuff much, much too slowly. And I think, as Elizabeth said, the kind of work that's going on in communities around the country can actually help with that. But if we look to the future, you might say, well, how's this all going to fit into what's happening at the federal level and around the country? So are these ACOs going to solve all the cost and quality problems? And if they do we even need these regional health improvement collaboratives anymore after all of that? Well, I'll tell you, regional health improvement collaboratives, what we call RHICs for short, can actually be incredibly helpful in getting ACOs both to start and to succeed. Because if you're trying to form an accountable care organization, who should you partner with? If you don't know who are the good, quality, efficient providers in the community, how do you figure out how to form one of these? If you do put together an ACO, where do you get the data to actually be able to figure out how you're doing and where you're going to improve and where you're going to actually generate those savings that you need to be able to manage under new payment models? How do you get your physicians and your frontline staff to be able to redesign care? All of those things are things that regional health improvement collaboratives provide by being able to provide both data and the kind of training and coaching for frontline staff to be able to improve. And then how do you get all the payers to participate? It doesn't work for providers to say one payer is changing and all the other ones are still paying under the old pay-for-volume model. So getting all the payers together in the room to be able to change payment across the board is incredibly helpful. And then how do you get those patients engaged? Because one thing every physician always says to me is, okay, I'm willing to do something, but what about the patients? How are we going to get them more engaged in improving their health and using the right kind of high-value providers? There's another thing about ACOs that people has been lurking in the public discussion is, are ACOs just good ways to coordinate care, or in fact, could they turn into big monopolies that just raise prices? And this is something that regional collaboratives can help to do because they are community-based. So they can actually work with the small providers in the community so that you can have multiple successful accountable care organizations and have some competition and preclude total consolidation. You can educate the stakeholders in the community about whether or not the things that providers are doing are actually improving value or whether they are not. You can have measurement and reporting to say, are the accountable care organizations in the community actually improving things? Are they making things better? Are quality going up and is cost going down? And by working across the country, we can figure out how to compare so that when the accountable care organization in your community says, we're the best that we could possibly be, we can say, well, gee, there's one in some other community that seems to be doing a whole lot better than you are, and maybe there's more opportunities to do that. Now, accountable care organizations aren't the only thing that is being pursued nationally. We've got bundled payments, readmission reduction, medical homes, care transition, insurance exchanges. So is there a role for these community efforts to play in that? Well, for example, bundled payments getting a lot of discussion today. So who actually decides what's in the bundle? Well, if all the payers independently decide what's in their bundle, so there's the provider who ends up with 7 different bundle definitions that they're trying to figure out how to manage. What if each provider decides what's in the bundle? So then is every payer supposed to come up with multiple changes in their claims payment system to pay every provider on the bundle that they most want to be able to get? And what if the payers don't want to buy what the providers offer? And the providers don't want to do what the payers are trying to encourage? So what's the answer? First of all, it starts with data. You absolutely have to have the kind of data so that physicians and hospitals can actually analyze what's going on and figure out where the opportunities are. And then you have to have some neutral facilitator to be able to bring them together using common data. If we end up having dueling pie charts in the meetings, we will spend more time debating about whether the data is right than whether we can actually improve care. And then there has to be a willingness to collaborate in the community to be able to improve. A lot of effort going on in readmissions, but I think we don't have anything near enough comprehensive approaches to readmissions. Readmissions are not just a hospital problem, and you don't solve them just by improving care transitions. You've got to get everybody engaged: inpatient care, transitional care, post-acute care, long-term care, primary care, specialty care. Every aspect needs to start working together, and it has to be driven by what the data say are the sources of the problems. So what are the real keys to success in all this, and what are the barriers to progress? Well, as Elizabeth said, absolutely critical, all the stakeholders have got to be at a common, neutral table. And the truth is, it can't be one big national neutral table. It's got to be dozens of local tables, because that's where healthcare is actually delivered, and that's where it's improved. It's the stakeholders in the communities that have to be talking to each other. And there's one major stakeholder that's almost always missing from the table. Guess who that is? Medicare. Now that's starting to change, because in fact Medicare is now actually participating through the Comprehensive Primary Care Initiative in 7 markets around the country. For probably the first time in history, Medicare is actually at the table with other local payers coordinating their efforts. So that's good news. Data, you heard data, 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 and data is absolutely critical, because what happens in these discussions is that people come in without data, everybody assumes the worst. This is going to be bad for me, or I'm already doing as well as I can, etc. So data that's objective data is the basis for the feasible solutions. Most physician practices don't know how they're doing in terms of how often are their patients going to the ER or the hospital. How are they actually doing in quality? Most hospitals don't know what happens to their patients after they're discharged. And most people can't figure out what anything costs today, because all of that's secret. So the answer is you have to actually have data and analyze it to help physicians and hospitals find the opportunities, and then help them get ongoing data so that they can actually improve on a continuous basis. And I should say, you know, Todd Park talks about how data is oxygen. If you've heard Todd Park, I won't jump on stage like Todd. But he talks about how data is oxygen for healthcare entrepreneurs and innovation. But, you know, it's not just data. It's information. And one of the challenges is there is tons and tons of data out there, but somebody has to be able to actually turn that into usable information. And that's what we're doing around the country, is doing that. One of the big barriers that we have is being able to actually get the data. Getting data from health plans and from Medicare is a huge barrier. And if you recognize how critical it is to have the data, then not being able to get it, you can see, is a major barrier. And today, we're facing that even when we have data, we don't actually have data on the cost of care, which makes it very challenging to actually do things to improve the cost of care. Now, all this good work, I have to say, and you should be aware, is at risk. And I hope you are impressed with what you hear today, but recognize it is at risk, because a lot of it has been funded with foundation dollars. And the Robert Wood Johnson Foundation has been one of the leading supporters of this effort through their Aligning Forces for Quality program, but that program is ending in just a couple years. It is very difficult to be a neutral stakeholder convening table if you are only relying on funding from one stakeholder to be able to do that. But the problem is all the stakeholders are challenged right now. Insurance reforms makes it more difficult for health plans to contribute. The recession has made it difficult for employers to contribute. And if providers are facing fee cuts across the board, very difficult to them to say, hey, how'd you like to contribute to this regional collaborative effort? And right now there is no funding at all. There is no funding stream from the federal government to support what we believe is one of the critical elements for success in actually being able to achieve success on federal health reforms. Now, a lot of people say, well, you know, how can you have a federal program when there's not a collaborative in every community? And it's true, there's a lot of white space in the country at the moment. But a third of the population already has a regional health improvement collaborative in the community. So that's a pretty big start. And the rest could too, if we actually recognize the importance of this and support these efforts in communities around the country. And that's what NRHI is trying to do, is to serve as a mechanism both for incubating and supporting regional health improvement collaboratives so people don't have to learn this all from scratch the way the people you will hear from today had to do, but give the other communities a head start. And I would tell you from talking to communities around the country, there are lots of places in all those white spaces that are interested in doing this. It is remarkable how often when I go and talk, for example, to a physician group or a medical society in a state, and I talk about the notion of a regional health improvement collaborative, I talk about all kinds of things in the presentations, and what's the one thing that they come up to me to ask about? How could we get one of these regional health improvement collaboratives in our community? Because the idea of having a table where everybody can come together and actually try to work out A win-win-win approach to this is an incredibly attractive prospect and is something that most communities don't have but need. So we hope that if you, in fact, are impressed with what you hear today, don't tell us if you're not, is that you will actually help us make it easier to start and sustain these kinds of efforts. How? First of all, we absolutely have to encourage all the stakeholders to participate, because the whole notion of having multi-stakeholder solutions is that the stakeholders have to come to the table and understand that they actually can succeed. Second is that we have to get data. Absolutely have to be able to get data. And openness in terms of data from private payers and from Medicare is absolutely critical if we're going to be able to analyze and find the opportunities. We hope that federal programs will actually be more proactive in utilizing regional health improvement collaboratives to help implement key initiatives, whether it's measurement of quality, cost, and patient experience, whether it's payment reform, whether it's performance improvement for providers, because these mechanisms in the community can actually help make them far more successful than anything that's a one-size-fits-all solution from Washington. And frankly, we need financial support. We need financial support from all the stakeholders to actually help regional health improvement collaboratives have adequate resources.